Millions of laborers make up India's transient workforce. They operate as highly mobile nodes, constantly relocating across different geographic districts to follow employment. Legacy healthcare infrastructure fails when these individuals move across state lines. Their medical history is stored on localized hospital servers, and it does not travel with them. This creates severe medical blind spots. When a worker arrives at a new clinic, the attending physician has zero visibility into their past diagnoses, allergies, or chronic conditions, causing immediate diagnostic delays. The operational cost of this missing data is high. Doctors are forced to order duplicate tests and redundant scans, burning critical time and financial resources. A healthcare system that binds static patient data to localized hard drives excludes a mobile population from receiving continuous medical care. The proposed solution is Noventrix, a cloud-native, centralized digital health record management system engineered specifically to ensure continuous care. The objective is to replace siloed hospital databases with a universally portable medical history that persists regardless of the patient's physical location. To achieve this, the back-end architecture must be capable of dynamically handling highly structured identity data alongside massive unstructured medical files. The first structural change is decoupling the entities. The system relies on a unified identifier matrix to separate the patient from the facility. The second requirement is strict clinical interoperability. The modern cloud backend must be able to securely exchange data with thousands of aging, localized hospital systems. Solving transient healthcare access requires treating it as a complex distributed database architecture challenge. Building this architecture from first principles begins by isolating the core unit of the network, the patient. The system assigns a unique patient ID, or PID. This node maps deterministic static properties like a patient's blood group and their Aadhaar number. This conceptual diagram shows the primary actors that will query the patient's node, the doctor ID and the hospital ID. Because these nodes are decoupled, a patient can grant explicit access to a new doctor across entirely different hospital networks. The system secures these many-to-many connections using JWT and OAuth 2.0 protocols. At the center of these connections is the Medical Record ID, or MID. This is the actual data payload containing diagnoses, test results, and prescriptions. By structuring the database this way, a migrant worker's medical identity persists in the cloud, completely independent of the server hardware at any single geographic clinic. Supporting this complex matrix requires a specific back-end storage stack to process the differing data types without bottlenecking. This block diagram details the architecture. A traditional monolithic database cannot handle both rigid entity mapping and heavy file storage, requiring a hybrid approach. Postgres manages the structured relational data, tracking the strict mapping between PIDs, DIDs, and HIDs with high query speeds. However, medical records contain high-resolution X-rays, MRI scans, and complex lab reports. Relational tables struggle to process these large, unstructured files efficiently. MongoDB handles this file-based document storage. It operates in parallel, catching the large, unstructured payloads so the relational queries remain fast. This polyglot persistence model provides the high-speed processing required to verify identities while maintaining the massive volume capacity needed for raw medical data. We can observe the clinical impact of this architecture by tracking a single routine blood test as it enters the system. In legacy electronic records, diagnostic data lacks a programmatic expiration parameter. A blood panel from 6 months ago looks identical to one from yesterday, leaving the physician to manually verify its clinical relevance. This JSON payload highlights Noventrix's solution, hard-coded temporal validity tracking. The backend assigns a strict validity window to the diagnostic data. It programmatically evaluates this window against the current system time to determine if the test results remain clinically useful. When a physician accesses a patient's history, the front end automatically separates the active test results from the expired data. This temporal awareness algorithmically prevents doctors from ordering redundant lab work by immediately surfacing valid recent diagnostics. To function, this centralized matrix must communicate with thousands of isolated legacy databases operating inside regional government and private hospitals. Writing custom API bridges for every distinct regional hospital architecture would create insurmountable technical debt and permanently halt the platform's scalability. Noventrix bypasses this integration bottleneck by adopting a strict clinical interoperability standard known as HL7 FHIR. FHIR standardizes the format for data exchange. It operates as a universal translator, allowing disparate clinical software to read and write information predictably. When legacy hospital data reaches the backend, the system normalizes it into the FHIR format before routing it into the Postgres and MongoDB databases. Adhering to the HL7 FHIR standard allows the identifier matrix to scale horizontally across state boundaries without generating friction during integration. Scaling this architecture to millions of daily network queries generates a secondary functional layer. The individual medical record payloads automatically feed an anonymized data stream into a centralized disease tracking module. The backend categorizes this aggregated diagnostic data, sorting it into active, recovered, and chronic disease profiles for epidemiological tracking. This map demonstrates the result. The architecture organically constructs a real-time pan-India public health surveillance network visible to government agencies. The dashboard monitors for anomalous spikes in specific diagnostic codes, allowing health officials to detect district-level disease outbreaks rapidly. Standardizing micro-level clinical interactions through the ID matrix organically builds a highly accurate macro-level epidemiological radar. The architecture shifts transient workers away from disconnected hard drives and into a secure, unified identifier matrix powering real-time surveillance. The system achieves this by utilizing temporal validity tracking to eliminate duplicate testing and enforcing the HL7 FHIR standard to ensure horizontal scalability. This yields direct clinical benefits. Physicians can execute faster treatment decisions, and a highly mobile workforce maintains continuous access to healthcare. Transitioning to this completely cloud-native environment removes the reliance on physical, paper-based records, reducing the logistical and environmental footprint of the health ecosystem. Engineering a secure, interoperable health ecosystem provides persistent medical identity and systemic visibility to millions of transient workers previously lost in the data silos.